Great. So welcome to the Implicit Spring Meeting. Happy to have you all here. Excited for kind of our agenda that we have and some speakers from different parts of our network and community partnerships. So first, I wanted to give the opportunity to kind of understand who all is here, because I think the great thing about the Implicit Network is we are bringing people from all different geographical areas, different sites, and that you also may be connected to the Implicit Network in a different manner than just a implicit site. So would love to have a brief introduction, so 30 seconds or less, just your name, your site or connection to Implicit, kind of your role within that, and then how long you've been with the network. So I will start. In case you do not know me, I'm Anna Federoff. I'm the Implicit Network Manager. I have been with Implicit Network since December of 2020. So it seems like it has flown by, but happy to be here. So I'm going to start off with Christy.
Hi, everyone. I'm Christy. I am the Western PA Implicit Coordinator, so I manage a lot of our UPMC sites and our AHN site, and I have been with the network since May of 2024.
Emily?
Hi, everyone. I'm Emily Long. I'm one of the program coordinators for the network. I mainly work with our Eastern PA sites, and I am based in Philadelphia, and I'm the lead for the Scholarly Activity Committee.
Amy Smith?
Hi, I'm Amy Smith. I'm with the Mid-Hudson and IFH Bronx sites in New York. I am on the Leadership Council and the Data Review Committee.
Allison?
Hi, everyone. Good morning. My name is Allison Myers. I am based in Cleveland, working at Metro Health, and I'm the Implicit Site Champion for our site, along with my colleague, Eric Kim. And we started the process of joining the network, I think, 3 to 4 years ago.
Hansa?
Hi, everyone. Good morning. My name is Kansa. I'm a second-year resident at LGH, Lancaster General Hospital, and I am one of the implicit chiefs there. And I've been with the network for just about a year.
Stacy?
Good morning, everyone. I apologize. I'm still driving, so I'm not on camera, but it'd be lovely to see all your faces very soon. My name is DC Bartlett. I am in Pittsburgh. I'm the site champion for a couple of sites here in Pittsburgh, and on the Leadership Council and the Scholarly Activity Committee and the Health Equity Committee. And I started with Implicit as a resident, so probably 2020-ish as well.
Dan?
I'm sorry, what did you just say? My name, Jan?
Yes.
Okay, sorry. Hey, so I'm Jan Bestie. I am in Wilmington, North Carolina. I have been the program director here, and I think we've been in the network for almost a decade. I can't remember exactly how long it's been. And if you don't mind, I'd like to introduce my colleague, Lauren Snyder, since she is going to be taking over my position when I leave this summer.
Absolutely.
Lauren, you want to introduce yourself?
We can try to come back if.
Sorry.
No worries. I know, first thing, getting everything on and situated. Chastity?
Hi, good morning. I'm Chastity Spagnola. I am at WellSpan York Hospital Family Medicine Residency. I'm the APD there, and I was a part of the network when I was a resident at Williamsport Family Medicine Residency, probably starting in like 2017 or 2018, and then started with the program when I moved over as faculty at York.
Cindy?
Just a second. I think well, my camera's not working at the moment. There it is. Cindy Barter, I'm at Hunterdon Medical Center and have been with the Implicit Network probably since I joined Hunterdon in 2009 or 2010. And we finally got to share data this last year. So excited about that.
Yes, congratulations. Bridget?
Hey, good morning, everyone. So I'm Bridget Klein. I work closely with Dr. Bestie at Novant Health in Wilmington. So I've been with the network for close to 8 years now, helping Dr. Bestie with data entry and just doing data with our site. Happy to be here again. Thanks.
Nargis?
Good morning, everyone. I'm Nargis Farahi, and I'm in North Carolina at UNC and at Piedmont Health Services. I serve on the Leadership Council and also on the Health Equity Committee.
Hannah?
Hi, I'm Hannah Dudney. I am with Tennessee Department of Health. We are not an Implicit site, but we are interested in expanding Implicit to Tennessee. So I'm joining to learn more about Implicit and hear about the work that you all do. So thank you for having me.
Layla?
Hi, I'm Layla. I'm a third-year family medicine resident at Lancaster General. I work with Bree Moyer and Kansa Bajwa. I don't have a specific role, but I kind of got linked in at FMAC and have enjoyed it, so here I am.
Mike?
Good morning, Mike Horst. I work as part of Penn Medicine. I manage the REDCap network database for both fourth trimester ICC and also help to support the R reports that sites and the network uses as far as all the data. I've been with Implicit since 2005.
Ashley? Not sure if you're speaking, Ashley, but we can't hear you. Unfortunately, I see that you're unmuted, but we cannot hear you. If you want to try to put it in the chat. Shanna?
Hi, everyone. I'm Shanna Klukar. I work for the Pennsylvania Department of Health, Bureau of Family Health. I'm in Harrisburg, and I've been the project officer for the Implicit grant through Title V funds since I think 2019.
Caroline?
Hi, everyone. So I'm Caroline Lefebvre. I'm based at Maine Dartmouth Family Medicine Residency up in Augusta, Maine. I've been involved for several years coming to meetings, but finally got approved to collect data this last year. So we're very excited to do that.
Laura Rule?
Hi, I'm Laura Rule, and I work with Cindy Barter at the Hunterdon Family Medicine Residency in New Jersey. And I help to implement the ICC model at one of our 2 family practice outpatient sites. And I think I started participating about 2 years ago.
May?
Hi, my name is May Reale. I work for the Pennsylvania Coalition Against Domestic Violence. I had the pleasure of providing some training to you all in November. So I guess I've been involved since then. I'm thrilled to be here again, and I'm just so excited by the work that you all do.
Mary?
Hi, Mary Desi from Wellspan Family Medicine in York, Pennsylvania. I am working on implementing the fourth trimester project at our family medicine residency clinic and have been working with Implicit since September, I think, or October.
Sherilyn?
Hello, I am Cheryl Lynn. I work directly with Scott Hartman. We are from Highland Hospital under the URMC. We also are lactation care managers, myself and Ashley. So Ashley's on here. I know her mic is not working. And we are actually guests. So I'm not sure how long we've been under the Implicit.
Welcome. Monica?
Good morning. My name is Mineke Etienne, and I'm the Associate Program Director here at the Ellis Family Medicine Program in Schenectady, New York. We just joined the network last fall, and so I'm excited to get more information and gain momentum.
Brianna?
Good morning, I'm Brianna Moyer. I'm faculty at the Penn Medicine Lancaster General Health Family Medicine Residency Program, and I'm the provider champion there. I'm also on the Leadership Council and the Data Review Committee, and I've been involved since I was a resident, so I guess since 2015.
Rathika?
Hi, I'm Radhika Namalendran. I am a family medicine provider at Mayhec Family Medicine in Asheville. I think Mayhec itself has been part of Implicit for quite a long time, maybe about a decade, but we've had a lot of transitions in leadership and faculty, so we're kind of picking it back up and, post-hurricane, hoping that we can get this moving a little bit.
Scott?
Scott Hartman. I'm at University of Rochester Medical Center. I'm on the Leadership Council for Implicit, and I think I've been involved since 2015. I can't believe it's been that long.
Laura Seams?
Hi, I'm Laura Seams. I'm with UPMC Altoona Family Medicine Residency. I'm the site champion there. And I think we've been with the network since 2018.
Lauren Snyder?
I think her mic is not working.
Yeah, I saw it just turned on. So Lauren, if you want to introduce yourself in the chat, I apologize. Samantha?
My name is Samantha Straka. I work at Novant Health in Wilmington, North Carolina. I work closely with Bridget and Dr. Bestie, but I've been at Novant for a year now, but I started doing implicit data work about a year and a half ago when I was an intern.
Did I miss anyone? I tried to go in alphabetical order, so if you jumped on while I
Hi.
was...
Hi, I'm Shalini Deltram. I'm from Penn State Health. I'm a research project manager there, and I believe our institution has been a part of Implicit since 2018, though myself, I started, oh my goodness, last year. It hasn't been quite a year yet, but yeah, I'm excited to be here.
Thank you. Anyone else that I missed?
You skipped me, which is why we're probably running on time. I just wanted to say good morning, Mario DeMarco. I'm a family physician. I'm at the University of Pennsylvania in Philadelphia, and It's a theme. I got connected to Implicit as a resident doing a QI project around 2009, and got more involved around 2012, 14 in that area, and joined the Leadership Council in 2017. And I do a lot of the grant work that supports the work that our network is doing, mostly in Pennsylvania, but also throughout the network.
Probably just skipped you because I assumed everyone knew who you were, Mario. Awesome. Well, welcome everyone. I hope this kind of shows like the diversity within our network, and also just thinking about the people who are here, and this really being a time to have conversations, collaborate, understand what's working well at sites, what some best practices are, how we can help each other. And I think like awesome, we have new sites and new sites sharing data. So welcome to everyone. Just a couple of reminders. This is a virtual meeting, and I know sometimes virtual meetings can, and it is a longer meeting, can be long, and just really feel like if you would like to say anything or have a conversation about anything, ask any questions, please feel free to raise your hand. Some sections we're trying to dedicate some time to have more of a conversation, but we really do want this to be interactive. We will have one designated mid-session break. Otherwise, I know this is long. I know sitting for this amount of time, please feel free, take additional breaks as needed. Feel free to eat breakfast, lunch, but welcome. So just a quick overview of our agenda. We will try our best to stay on time. As always with our meetings, sometimes some sections end a little bit early, sometimes some sections run a little bit long. I'll be monitoring the time and trying to make sure that we can keep to it as best as possible, but we will have a hard stop at 2 o'clock. And potentially even some years we finish a little bit early, so. I do want to just recenter us, and we've had this conversation and are committed to this as a network of just having gender inclusive language. We are doing this to the best of our ability, but that being said, we know that sometimes we do make mistakes. So please know that really when we are talking about mothers and birthing people, that we are trying to be very inclusive of all gender identities within that framework. So to start us off, I want to give some updates. A lot has been happening within the network, so really just wanting to hone in on kind of some of these different things. So in the fall, we started working on updating our network membership, and this was really to clarify some of our different membership categories. So looking at emerging sites, active sites sharing data, active sites not sharing data, and kind of creating an affiliate membership category. And with this update, we really wanted to think about what our membership includes and how we can make it the most beneficial for our sites. So some things with the memberships is we are working towards having CME credits available for webinars and being an organizational PI through ABFM. So you will get more information about that coming up. And then the big thing is we did increase our membership dues. This really is a process to support building a sustainable network and supporting Implicit staff and trying to continue to grow the network. You all should have received some format of invoice, and that change was reflected in 2025. If there are any questions or concerns about this, please do not hesitate to reach out to me. The other update was with our participation agreements. After having some conversations with some different sites, we know every site within our network has different capabilities of being able to share data or not. Obviously, our gold standard is trying to get to the point to share data, but we wanted to also create a participation agreement that reflected sites unable to share data. So we now have kind of those two separate participation agreements. With the updates, we also fixed some typos and language that was in there, and then clarifying what our network obligation is to you as a site. So everybody should have been sent an updated participation agreement towards the end of 2024. It was sent at not the most ideal time in between Thanksgiving and Christmas. So just look for follow-up emails if I have not received a signed copy of that. I'll just be reaching out to you to get that as soon as possible. So next, I want to kind of give an update of where we are as a network with grants. We have a lot of things happening in this space. So these are our current active grants. So we have a grant with the Pennsylvania Department of Health, and that historically has really helped grow our network by creating a very strong hub within Pennsylvania and having our coordinators really be able to grow Pennsylvania and use that as a framework for the rest of our network. Unfortunately, that grant is ending June 2025. It has been a great experience and partnership. And in the next couple slides, we'll touch on potentially a new way to continue a partnership with the Pennsylvania Department of Health. So the next grant is a newer one, is the HRSA State Maternal Health Innovation Grant. And this is a collaboration with the Pennsylvania Department of Health, the Jewish Health Foundation, and Penn Medicine. And that award has been received, and we're working on the final, crossing the final T's and dotting the I's. And that is supposed to be live starting in 2025. So that really is looking to increase what we're doing with our fourth trimester model, but also working with the Jewish Healthcare Foundation to really understand the needs within Pennsylvania and different counties, and highlighting those counties and how we can use what we do as an implicit network to improve maternal health outcomes in those counties. The other grant that we currently have active and have received is the ABFM Foundation grant. So that is really looking to expand our reach in Minnesota and Tennessee with family medicine residency sites. So that work is happening now and ongoing, and really looking to add some new sites in Tennessee and Minnesota. So next, our current grant submissions. We have been really trying to work hard to increase the funding for the network and sustainability and grow our network. So we did apply for a Centene Corporation grant. Unfortunately, it was not funded. We have a couple grants that are currently submitted. So the Action for Women's Health grant, which is the Melinda Gates grant opportunity. We've officially made it to the next step. So we are now in the running with about 4,000 other applicants. So great opportunity. We are shooting our shot and seeing what happens, but we'll keep everyone up to date on that. Another smaller grant opportunity, Shadyside Hospital Foundation, to really continue to support our Western PA position as our Pennsylvania Department of Health grant ends. We have a couple grants in the works right now. We're working on a PCORI kind of special topic grant that is focused on intimate partner violence. So really, how can we improve our screening, education, and addressing positive screens for that within our fourth trimester project? We are also working on a craft prize for excellence and innovation in community health. And this one is focused on kind of working in some more rural areas of Louisiana or Mississippi. And that one will be submitted next week. And there's the opportunity, if we receive that grant, to present at the Mass General Brigham World Medical Innovation Forum. And then the final grant we're working on right now is the the Pennsylvania Department of Health recently released an RFA to promote the use of promising and practice-based solutions to improve maternal health outcomes and health equity in Pennsylvania. So we're just in the early stages of this, but really looking at focusing on fourth trimester and transitioning from maternity care to primary care in counties that we are in, and then also counties that we're currently not in that are more rural areas, to increase the access to kind of maternity care, primary care, bridging. And then finally, some potential grants that we're looking at. We are looking at an RF Kellogg Foundation grant opportunity, which they have a maternal health priority area. And this is kind of a grant that we can apply at any time. And we're looking at potentially applying for this for a capacity building opportunity for the network. Another smaller foundational grant through McKeesport Hospital. Again, that would be looking to support our Western PA coordinator position. And then a new grant that was just brought to us less than 24 hours ago, a CareSource Foundation grant. And really they also have a priority work in reducing maternal and infant mortality and have some specific state areas, majority of which we either have only a couple sites in or 0 sites in. So potentially looking at this opportunity as a way to take what we've done in Pennsylvania and how we've been successful with that, and try to use that as a template to fund additional work in some of these states and really continue to grow the network. So as we look at these grant opportunities, we know, and we'll talk more about this later, but there's obviously a lot of unknowns with funding opportunities and grants. So as a network, we're really trying to, apply to as much as possible, and with the hopes of receiving some to really focus on growing the network and being able to grow our staff to support the network. Always happy to hear from you all if you see grant opportunities, whether they're smaller, more local grants to help support the work you're doing at your site or in your state, or larger grants. It's really helpful for us to have opportunities brought to us that we can then start working on, figuring out how as a network we can apply for, and if it's something that's a more local, regional thing, how can we help support you as a site apply for it and help support the work you're doing. So the next update is the acronym. I would love to see just testing if anyone can write our current implicit acronym in the chat without looking it up. And just as a little test to see if anybody is able to do it, because I would say, my job is 100% implicit and I cannot do it without re-looking it up. So I'll give everyone 60 seconds to see if anyone can write it in the chat. And I don't know, Mario, if you count. So all of this to say, I'm seeing a couple no's. Oh, Amy, I feel like you also don't count. None of our LC members count. But all right. So obviously the point of this is the current acronym is long and it is very hard to remember. And also this acronym was created before fourth trimester. So it really doesn't accurately describe who we are as a network and what we're doing, because the acronym is very much focused on kind of our ICC efforts. And number one, no one can remember it. So that being said, the LC has been working hard to really fix this. So we would like to unveil our new acronym for implicit. So it is the Innovations for Maternal and Perinatal Care Improvement. So really hoping that this is an opportunity to have it be easier for people to remember and just better describe who we are as a network. So you will be seeing this announcement coming through via email, but also kind of some updates through our social media and everything. So appreciate the LC for all their work on this. We had lots of options and lots of discussion. So hopefully this is something that everyone can feel good about and ideally remember moving forward. All right, so with a new acronym, we are also working on creating a new website. Up to this point, we have had a page through FMEC, which has been amazing, and we really appreciate that effort on their part to have that information there. But we've talked about how if we want to continue to grow as a network and to have people see who we are and what we're doing, it's really important that we have more of a footprint and ability for people to find us. I know when I was first looking at this job and I tried to search the implicit network, it took me a very long time to find some information. So being able to have a website that's a really good hub for this. So with this, kind of some key things for this website, our goal audience will be kind of providers, residencies, community partners, funders. I think really bringing who we are and what we're doing to those audience members and having a space where if someone is interested or wants to learn more about who we are and about joining the network, they have that space. The other audience that we do want to be able to try to interact with more is the actual community and birthing people. So the first kind of phase of this website will be really focused kind of more on the first section, but with some resources for birthing people. And then we would like to eventually kind of have a section more focused on that where we can have resources and really connecting and providing education. So with the website, we have kind of a tagline with it of innovative care to improve birth outcomes and support families to thrive. This website will also be a great opportunity to move away from our Google Drive, which we know that health institutions since COVID have really been cracking down on the access to get into Google Drives from your health institution. And we know that that's, a limiting factor for you being able to access network related stuff on your own without a coordinator or myself accessing it for you. So we will have a membership only section where you will create a login and you will be able to access things like workflow, example IRBs, educational resources, kind of you'll have the network meeting recordings there, webinar recordings, all of that stuff. So we're excited to have that opportunity. I are looking for any recommendations of anything you would like to see on the website that you think would be really important to have. And I do want to really quick give a quick peek of the website. Now, again, this is early stages. It is not complete. So kind of just an initial look, having our first homepage where we highlight some of our initiatives and our impact of where we're at, who we're directly impacting. And then in our About section, we'll have kind of the focus on our mission, vision, values. Here we will highlight our supporters, so our grant foundations, organizations like FMEC that we've been partnering with and have been supporting us. And then having a history section. So under our projects, we will highlight each of our care models. So 4th trimester, and really being able to kind of look here of what this model looks like and what we're doing. And also why we're doing it. So framing kind of the current state of maternal health. And then ICC is not updated yet, but we would have the same for ICC. And then under our initiatives, focusing on kind of our committee work. So like our scholarly activity, highlighting our publications and having that all in one easy place to access and to have that. Resources. So the goal of this would be to have some patient-facing resources, also having some resources for providers or sites to learn more. So things like our one-pagers. Events. Our goal with this is to kind of have a more available calendar. So if you're interested in joining a committee meeting, you can easily go to this and see when the next committee meeting is. Also having our network meetings and webinars on this with the goal of having a little bit more of a formal registration. So we're not just relying on the listserv, which we know has been not the most reliable lately. I know I've talked to a couple people individually of kind of some issues with that. So being able to have a little bit more of formal engagement instead of just sending out a calendar invite via our email. And then news section, this would be really highlighting, like, you know, we have 2 new sites that are sharing data this year. So highlighting that, highlighting events like the March for Babies and that work, highlighting when publications are happening. So things like that. And then our membership section, this would be where kind of the registration login and where some of these membership specific resources are on here. So again, this is just a quick glimpse. It is still very much being worked on. Mario, that will not be the new website name. But wanted to briefly open it up to you all to see if there's any input, or if you want to put it in the chat of any recommendations that you would like to see on this website that you didn't see or I didn't touch upon. All right, so just as a heads up, our ultimate goal was to have this website be ready to launch by this meeting. Like with anything, we have realized it takes a lot of work and a lot of time, even though we do have a website designer helping us. We still need to do a lot of content creation, and I think some of that content creation is taking what we already have, but making it more formal and universal for all sites or all people to come and look at. Hannah, do we know what the web address will be right now? And do not quote me on this, but I think our domains that we have is implicitnetwork.com and implicitnetwork.org. But we will be sure to share that information with you all when it is officially live. So I think our hard goal is very much having this done before the fall meeting. And I I greatly think that's possible. I think ideally would love to have this ready to launch by summer. So webinars, so this is kind of a new thing that we are really pushing for this year, is having CME credits for webinars. So we are going to be going through AAFP with FMEC support to do this, and kind of going in an advanced pathway, which just means that we're going to submit an application for a year's worth of topics, and then have each of those each webinar would be a specific amount of CME credit. So we do not have this finalized yet, just because we are finalizing our current upcoming topics. We have kind of narrowed the topics down to focusing on birth experience, birth trauma counseling, smoking, vaping, marijuana use, looking at Medicaid medical assistance and how some of the new changes could be affecting patients. And then also premature births and how to support patients who have preemies in the NICU or have just gone through that process. So right now we're just finalizing speakers for these topics. And once we have that finalized and have some rough dates, we will submit this application and then have those webinars scheduled and let you know. But these would be the upcoming topics for 2025, potentially a little bit into 2026. So if we submit for a year, it'd be potentially April 2025 to April 2026. So again, as always, if you have a person or speaker or topic that you are really interested in or think would be really beneficial for us to see, please reach out, bring that to our attention. We're always looking for new presenters, new topics. I think, it's helpful to get input from other people and other sites, because I think that's part of the benefit of this network, is really, can we bring experts in these topic areas from all different regions of the US? And also, what are you interested in learning about? So we hope by offering the CME credits that we know you all are very busy and have lots of competing things for your time, that this gives you a little bit more reward for attending a webinar, and just, kind of acknowledges that we know your time is precious and we want to make sure that you can attend, but also receive a benefit from attending outside of just the education from it. So now into some committee updates. So first, with the data review committee, just kind of some current projects that we've completed. I say some of these projects are, the data committee providing input, and then Mike being our biostatistician superhero who takes all of our crazy ideas and brings them to fruition. So updating our ICCR report has been completed. We were part of the committee supporting the updating data sharing participation agreement, and transitioning our fourth trimester care model from phase 1 to phase 2. So that was working with a lot of questionnaire updates and just fine-tuning the model. So currently, kind of our in-process work, we are updating. We provided lots of advice and input for Mike. He is working on updating the fourth trimester R report, supporting our PDSA cycle and goal metrics with that, supporting scholarly projects and resident projects, exploring the use of Epic Cosmos as an idea of having a potential access to a larger data repository to look at some bigger questions outside of just our implicit data, supporting grant applications, and then, as always, critically looking at kind of what's happening with our data. How are we doing? Is there potentially a better way to ask this question? Is there a new question that we should be thinking about? So our data committee meets every second Tuesday of every month, 5:30 to 6 p.m. You do not have to be a data guru. Sometimes it's really helpful, especially if you may be having data questions about at your site or just questions in workflow and how this is implemented. We would love to have you join and have those conversations. But then just kind of looking at the ICCR report update. So this update should not be too new to you all because this has been presented. Kind of the big section is updating our behavior change section, and Mike has been able to present on this the last couple of meetings. So really having a better way to look at our behavior change data. So again, there are some other updates like updating all of our language to make sure we're using gender inclusive language, and just some of the updates that we had made recently with our family planning contraception question. So if you are interested in looking at a full report and especially your site's behavior change data, please reach out to your coordinator and let us know. We're happy to get this for you, and we're happy to have you look at it and then schedule a meeting to talk through it because it is very dense and can sometimes have to parse out what's happening and what's it looking like. Now I will pass it on to Christy.
All right. So I'm Christy. I'm the chair of the Health Equity Committee. So here are some of the current projects that we're working on. We're looking at the Health Disparities Needs Assessment Survey. Some of you have been with the network for a couple of years. You may be familiar with this survey. But what we're going to do is reevaluate the results and determine some possible steps to close out the project, which could include publishing on the results. We're also working on the Site Community Partnership Survey, which again, some of you may be familiar with, an educational social media series, some legislative support language, and we're looking at disaster response and mutual aid, kind of looking to highlight organizations to support in communities dealing with a disaster. And our completed projects thus far this year have been the network statement that went up on social media a couple of weeks ago, and that will be sent in an email to you all in the coming weeks. So just going into some more detail on the Site Community Partnership Survey. This survey collected some information on community partnerships from different sites in the network. So again, some next steps that we're looking at. First, we're going to review the results. We're going to identify some network partnership priorities and how to maintain relationships, and maybe try to collaborate with different organizations for webinars and social media to kind of improve and expand upon these partnerships. So the first part of the Site Community Partnership Survey was asking respondents to identify some postpartum or interconception needs of their patients. And access to doulas was the most cited need, followed by mental and behavioral health needs and food insecurity. And then another part of the survey was asking people to kind of talk about their partnerships. Who were they partnering with? Maybe a little bit more about that partnership, how long you've been partnering with this organization. So we had a couple of answers. People partner with their local WIC office. We had a few places in Rochester, like the Rochester Baby Network, the Rochester Consortium to End Black Maternal Mortality. One site partners with pelvic floor physical therapists to bring that to their patients. Some sites partner with certified lactation consultants. A couple of sites in Philly talked about the Lutheran Settlement House, Cordea, the Nurse Family Partnership, and Philly Families Can. Another site talked about the Hunterdon County Partnership for Health. A site in Pittsburgh talked about Kangaroo Birthing, which is a doula service. And one site talked about Nourish, North Carolina, which helps out with patients facing food insecurity. And you can see the length of the partnership really varies. So we have some very established, long-standing partnerships and some newer partnerships. And then another part of the survey was just asking respondents to identify some benefits and challenges that they face with their community partnerships. So these are some examples of choices that people chose. Some benefits could have been establishing trust with their patients, facilitating transitions or continuity of care, addressing social needs, advancing equity, providing emotional or mental health support, and increasing patient or provider knowledge and education. And some challenges that people could identify, staff turnover and low patient utilization, some challenges with communication, competing priorities, budget constraints, and a fragmented system. And then we gave people an opportunity to write freely in a freestanding text box just about what an ideal community partnership would look like to address health needs in the postpartum and interconception period. And these are some themes that we pulled out of those answers. Some of the themes are having the partnership be led by patients and community members. People talked about more and better communication, people wanting the partnership to be centralized and cohesive, not quite so difficult for patients to navigate, an interdisciplinary partnership, having clear goals and outcome expectations, having it be easily accessible, and having access to early referrals and evaluation of patient needs. And then talking a little bit about one of our other projects, which is the legislative support language. Legislation has a tremendous effect on our practice and patients. And there are upcoming opportunities to support legislation that can help our patients, especially when we're talking about state legislation. So the Health Equity Committee has drafted a general letter of support that will now go to the Leadership Council for some feedback and any edits. Just some examples of some legislative priorities that we're looking at, some paid leave policy, and insurance reimbursement policy.
Thank you, Christy. I just want to let everyone know that we will be coming back to talking about some of the community partnership conversation a little bit more in our breakout session. Emily?
Yep. Hi, everyone. Again, I'm Emily. I'm the lead for the Scholarly Activity Committee. So just a few updates about just some general things that we've had going on with scholarly activity. I've been working on basically cataloging all of our presentations, posters, publications that we've done as a network since dating back so far right now to 2008 until present. And so that is now in the Google Drive, which hopefully eventually will live on the website once we have that membership resources page up and running. But Anna, if you have that pulled up, we can kind of like just go through it real quick, just so that everybody can see what it looks like. So this first page is a bit of like a key. So anything green would be a published paper, and then yellow or orange, however you want to say that color, is an oral presentation, and then the red is a poster. So that first tab right there is the master log of all of our scholarly activity. And so right now, the way that it's ordered would just be by year, but you are able to filter it by a bunch of different factors. So if you click right that little calculator button over there next on the top. Yep. So all of those different ones you can filter by what conference it was presented at, if it was a presentation, whether if it was ICC or fourth trimester, what publication, if it was a published paper, what risk factor or topic, what site did that project, what type of scholarly work, so whether it was a poster, presentation, or publication, and the year that it was done. So if you were to click through any one of those, it would just basically organize the spreadsheet so that you can filter it and look through it however you would like. So that is pretty much up and running. It's a living document, so it'll be consistently updated every year as we, do more of these projects. The thing that we're working on also as well is a research priority list. So this is a very rough draft. We're actually working on kind of overhauling this whole document, but this will eventually be all the research questions that we have as a network, and we'll be organizing them and describing them, eventually hopefully having them listed by priority. So the idea of this is so that, we do have a lot of students or residents that do come to us like looking for projects and things like that. And so we'll be able to have this document readily available for people to kind of look through and pick out any projects, and we kind of prioritize what our research priorities are as a network for that as well. All right. So, and then if you go to the next slide, so these are just our conference submissions for this year. We've had about 6 submissions to 6 different conferences. 2 of them were accepted. I believe that the Association of Maternal and Child Health Programs conference was last week, so the Implicit in Minnesota presentation did happen already, which is awesome. We have a few more submissions that we are still waiting to hear back on. So that'd be at the STFM QI conference, FMEC, AFP, and then 2 submissions for AAPHA. So those conferences are all in the fall, and hopefully will get accepted, and Implicit will have a presence at those as well. And then this is our works in progress right now that we're working on, any scholarly activity in the network. So we do have a good amount of projects going on right now. So we are working on a 4th trimester outcomes paper. That's been consistently meeting once a month. We're hoping to have the paper published, or submit for publication by the end of the summer, so around August or September. The 4th trimester implementation project, that's pretty much done for publication. The goal was to submit around this time, so just waiting for an update on that. We have a project on contraception behavior change that's in the early stages, as well as a multivitamin QI project that we have one of our medical students and one of our residents, Kanza, working on. And then we have our network QI project, which I will be talking about in a little more detail next, that we've been working on as a network. The qualitative 4th trimester study that was presented at FMEC last fall and at the fall meeting, that they are working to recode some interviews, and the goal is eventually, I think, to publish that as well. And then we do have a publication that was done by Brianna Moyer, and she has a narrative piece that was accepted into the Journal of Family Medicine. So excited to see that, and we'll be sending it around to the network once that comes out. All right. So now we've been talking about this for a little while, but the ABFM organizational PI project, which is our network QI project. So for those who don't know, the ABFM does allow for organizations like us to basically have a quality improvement project that any provider can participate in as part of satisfying their ABFM PI requirements. So what we're doing as a network, so this project, our focus is on improving ICC screening and intervention rates at well child visits at our Implicit network sites. So overall, we've seen that ICC has declined, that overall screen rate, which is the rate that ICC is being done at any well child visits, has declined by about 15% over the last 2 years. And that overall ICC screen rate for the last 2 years, so about January 2020 2022 to December 2024 has been about 66%. The ICC screen rate when mom or birthing person is present has been stable, but we do know that there are some well child visits where, it's not documented that mom or birthing person was present. So this rate may be lower than it seems. So often we kind of look at that overall ICC screen rate as an indicator as well. So our improvement goal will set an overall network goal, which I'll talk about a little bit later. And then we also, each site that participates will also have site-specific goals, because we know all of our sites have different sizes of patient populations. So, we want to be conscious of that. For the timeline, so the overall cycle is going to last 2 years. So this project will be live through ABFM for the next 2 years, but the individual projects that people complete as a part of this will likely have shorter timelines. So if you are interested in participating in this, your project does not have to last 2 years, but you are able to participate in this project anytime over the next 2 years. The measures that we'll be mainly focusing on to see the improvement, hopefully from this project, will be the overall ICC screening rate, the screening rate when mom and birthing person is present, the intervention rate for each risk factor, and the number of screens for each risk factor. And so whatever project you do doesn't necessarily have to focus on every single one of those measures, but likely it will focus at least on one. Okay, and so the interventions, so what you would do as part of this project. So these are just some ideas to kind of kickstart some QI projects. If you're interested in participating, you don't necessarily have to do exactly one of these projects, but it will be provided to you as kind of a list to start brainstorming. So we have some education intervention ideas, workflow changes, and risk factor intervention improvements, but you're welcome to create your own intervention for whatever you decide to improve at your site. And then we do have some meaningful participation standards in order to receive credit. So the idea is that we would have a provider create an implementation plan, and that could be utilizing any of the following. So recent data, any QI surveys, stakeholder engagement, any literature review. You choose an intervention and implement it at your site. You would review data so that we can see if that intervention did have, the intended effect. And then we would just have quarterly at minimum check-ins with us so that we, can provide any support that's needed for your project. And so there will be a REDCap form that we'll eventually create, and so that you'll be able to fill that out and attest to meeting those meaningful participation standards, and that's how we are able to give credit. And so I'm sure most of our Pennsylvania sites have been seeing this QI survey floating around since about November of 2024. So this was intended to kind of kickstart this ABFM QI project. And so we were looking at ICC and seeing how what our responses were for sites for QI for that. So we have had about 151 responses so far from our Pennsylvania sites. Most of our responses, or at least half, are from residents, and then almost all of them are family medicine providers and do provide pregnancy care. So eventually, because this is a network-wide project, we'll be rolling this survey out to the rest of our sites. But right now, we're just taking kind of a peek at some of that Pennsylvania data. And so this is just a brief snapshot of some of the initial takeaways from the QI survey. So the hardest risk factor to screen for based off of our survey responses so far was family planning. And the most common barrier that we saw in responses was the lack of time during well child visits for screening or interventions. And so some suggestions for workflow, which may be helpful when people are thinking about what they would like to do for interventions for the QI project. Would be that screening could be completed before the visit, so either by the front desk, by the patient themselves, or by an MA or a nurse. Having risk positives identified before the visit starts also was suggested, and then just some more resources that we're readily able to provide to patients when they do screen positive for intervention. So hoping that we can use these findings to inform this QI project. Okay, and then finally, this is just a snapshot of the goal metrics that we would like to achieve as a network. So on the left-hand side, you can see that's our data from the previous 2 years, some from January 2022 to December 2024. And then on the right-hand side, that is our network goal that we're hoping to see by the end of this PDSA QI cycle that we're doing with ABFM. So we have goals for, the well-child visit screen rate with mom birthing person present, and then the intervention goals for each. And then, so that's our network goal. We are going to work with each site that's interested to also have their own specific PDSA goals that are based off of their data. Yeah. Okay. And so finally, if you are interested, we do have a registration form that is live. So you're welcome to scan that and fill it out. I will be sending out an email with more information, but feel free to send this around to anybody at your site that may be interested in participating. You also can find this project. It is listed on the ABFM website in the catalog. So if you were to look on their website for all the organizational PI projects that they do have available, I believe it is called Implicit ICC QI Cycle. So if you were to search for that, that is how it would show up. And yeah, just, if you're interested, feel free to reach out, and we're excited to get this going with the network.
Thanks, Emily. And we are working with Sarah Jones, one of our LC members and pediatric provider champions at Mississippi, to get this so that our pediatric providers can use this project and it through ABFM to get the equivalent of that recertification requirement for their pediatric license and get participation through that. All right, so I am going to stop sharing my screen and pass over to May.
Awesome. Thank you so much. Hi, everybody. While I am getting my screen ready to share, I'm just curious, how's everybody feeling? Like, it's Friday, and here in Western PA, it's super sunny. So like, drop it in the chat, or I don't know, on Teams, it's hard to find the right emoji, but tell me just how are you feeling today? I'm so excited to be with you all and have the chance to really lean into this exciting conversation again. And I just want to mention before I do anything else, while I'm getting my PowerPoint up here, I am very informal. So I have a PowerPoint. I would much rather we have an amazing conversation than get all the way to the end of the PowerPoint. Also, I don't do the work that you all do. So because I don't do the same work that you all do, it's important to me if you're like, oh, that doesn't really fit, or tell me more about how this would track because that scenario doesn't make sense for me. Let's have that conversation instead of being like, I don't like this scenario. Let's just talk through it, okay? Also, I tried to make this as interactive as possible. I threw in a couple word clouds. I'm going to ask you all to talk to me. So please, if you feel comfortable, I really encourage it. It would be really make me feel like it's a huge pleasure. Can you see my screen?
Yes.
Does it look okay?
Yes.
Awesome. Cool. So thank you. So I want to just, before I do anything else, from my sincere soul, as a person who has spent a career at the intersection of domestic violence and health, I want to say thank you for what you all do. It is hard work and it is incredible work. And I just want you to know we see you. So thank you from me and also from the coalition for which I work. If you're like, who is this? What is the PA Coalition Against Domestic Violence? So every state has a domestic violence coalition in every territory. So but the kind of the caveat is that we are all slightly different, but just in Pennsylvania, just to center why I have the pleasure of speaking with you all today. We are the leaders. We sort of head a member network that comprises local domestic violence organizations. And in Pennsylvania, it's those local organizations that are organized by county that do the direct service work. Like, for example, I saw on one of your slides that you're partnered with Lutheran Settlement House if you're in Philadelphia. Philadelphia, and that's one of our member programs. So they're the people that do that direct service with survivors of domestic violence. And as a coalition, we don't do direct service, but it's our role to engage in opportunities like this, and also to help keep kind of that like domestic violence component as front and center as it can possibly be. So I'm hoping that you all would be willing to meet Lisa and Emily, and I just want to get a feel for how you all feel when you encounter this situation. So, how you, as the person who is reading this or maybe interacting with this situation, how do you feel about it? So you can give the QR code a scan, or you can pull up the poll everywhere. Hopefully this is going to work. We're going to see. So Lisa, a patient's mother, accompanies her daughter Emily to a checkup. While Emily is in the exam room, Lisa quietly shares concerns that Emily's partner Ryan has been controlling and making some threatening statements. So just right away, what comes up for you? I'm going to start our poll. And hopefully you can drop that in the chat. Or not in the chat. If it doesn't work for you, oh, I see there's already responses. This is amazing. Okay, does the person have weapons, safety? What else? Concern? Keep them coming. There's no wrong answer. And this should have let it be anonymous. Concern, safety plan, domestic violence. Yeah, worried. Oh my gosh, look at all these. You guys are great. Threat, planning, thoughts, safety, right? I'm loving seeing safety and awareness as like the big concerns. Help. Oh, great work. Yeah, I love that. Safety, concern, help, communication. Those are the cornerstones of how we're going to work with survivors. And in terms of today, we're really thinking sort of about that intervention piece. So as you are navigating through these scenarios and through our training today, these are really, you all are perfectly equipped to be moving into how do we do interventions with patients around that intersection of domestic violence. And also we're going to talk a little bit about some strategies that I want to put out there to help enhance some privacy so you can actually have some of these conversations and start the process of intervention. Thanks all for doing that. I really appreciate it. All right. So just to recap, I had the pleasure of meeting with you all and doing a recorded session in November. But I know that that was a long time ago. I know that not everybody necessarily had the chance to watch the recording. So just kind of quickly, survivors of domestic violence are everywhere. There's very few situations, there's very few environments where survivors don't exist. And I know that sometimes that can sort of feel kind of like an overwhelming thought. But the reality is that pregnancy and perinatal times are opportunities often, unfortunately, when people who use violence get extra access to coercive tactics. And so that's why we often see this sort of like increase in domestic violence during pregnancy and in that time right after. I want us to be also I want to be sort of mindful too that not every single act of domestic violence is physical. I've been in this work for a long time, and I know that when I came into the work, I had this sense that like, oh, I would be able to tell, right? Or a lot of the people that I would work with were going to report physical injury. And while that happens sometimes, it tends to not happen quite as much as we think, but often it may be something like someone withholding access to resources, making it really hard for someone to get to that well visit, threatening to take the kids. So those are things that often aren't illegal, but they create fear. They create that space where someone doesn't feel like they have a lot of power or a lot of choice. And those are the things that sometimes get missed. But like in our situation that we just talked about, right? There's nothing illegal that's necessarily happening. But there are things, right, that are bringing up concern. And you all identified that in the word cloud. So in terms of thinking about this, and I know this is hard because I like to fix stuff, but your role isn't to fix things. It is really to connect patients to supports. That's the purpose of asking these questions, of having the relationships where you may experience a disclosure. Leaving a relationship is not always wanted. It's not always possible. And that's especially true for folks that have kiddos. And even if they ended their relationship, they stopped that communication forever, I'm not going to talk to you ever again. It's just not feasible. And just because their relationship has ended doesn't mean that the effects of the violence have stopped. So they may physically end the relationship or no longer be in that home, but those effects linger. And sometimes the effects of domestic violence may not be, there may not be a situation of current domestic violence, but even prior situations of domestic violence bring a lot in for pregnant and perinatal folks. Survivors, they're the experts in their situation. And if you are in Pennsylvania, this always comes up, so I just want to make sure we're all on the same page. If you're in Pennsylvania, simply witnessing or a child being in a situation where there's domestic violence is not something that triggers a mandated report. All right, so I'm just curious, and I'm hoping that y'all will talk with me. Put it in the chat. Come off mute. But I know, right? I'm like, this has been my whole career. I've talked with survivors of domestic violence my whole life, right? But I know that there are some things that can make it really challenging. And I'm just curious because in order to intervene, you have to maybe know. So what are some things that make it feel really challenging to talk about intimate partner violence with every patient? Not just screen, but talk about it. And I'll get us started. What I hear from most of you all is time. Is that true? Time. Yeah. Lack of a trusting relationship with a patient you might not know well, and the partner won't leave the room. Thank you for bringing that up. Time to build a trusting relationship. Yep. So I think you all, it sounds like I feel like it's been pretty accurate, right? Also, sometimes I think people are like, I don't really know what to do if what my next steps are. I don't necessarily have a feel for that intervention. And also, I think there are barriers that patients have in talking about this with you all. And that's really that sense of like, I'm nervous about someone retaliating. And I think that sometimes the retaliation, again, it may not always be physical, right? It could be, but I think sometimes the more we think in terms of what, instead of trying to diagnose or like think about like, well, what is this person afraid of in terms of just being related, they're probably afraid of some response from that partner who is abusive. Concerns for child custody. This is to me the number one thing that we hear constantly, right? People who are abusive, they know how to manipulate systems. They know how to look really good in family court. They know how to make threats like, see, you used a substance during pregnancy, I'm going to report you. Right. They know how to use information, especially information that's overheard in health spaces, sometimes to create a situation where it's really challenging for a survivor to share with you. Lack of privacy, stigma and shame, previous negative experiences with healthcare and social services. I think that the reality is that people sometimes are paying the toll of prior bad experience, and that can make it really hard for someone to talk about this when it's really personal. Especially, we're not here to talk about the necessarily like the screening piece, right? We already had that conversation, but if it's simply a question, it can be really hard for people to even sometimes know what you're asking. And then just limited knowledge about what might happen around the disclosure. And then, of course, there's cultural and language barriers that impact trust and sometimes communication within healthcare environments. Any questions so far? How's everybody feeling? Everybody okay? All right. So I want to talk through again. I know I had the pleasure of sort of talking with Anna about like what were some things we wanted to talk through today. And one of the big things was getting that access to privacy to really do some intervention and really have some conversation. And I'm not here to say, oh, I have every single answer. I don't have every single answer, but I have a couple of ideas that I want to share with you all to find out, hey, how does this feel in your work possibly? So the first is avoiding that direct removal of partners. We hear about this a lot, that sometimes people will say, oh, like, we tell this person that they have to step out. And one of the things that we've heard from the people that have been asked to step out, right, is we know what you're asking about and it kind of feels weird, right? And so not to say that if this is something that you do, please keep doing it if it's a way to get privacy, but there may be a slightly better approach to it. And that is to try to create a space for some parallel but separate conversations. And I know that, like, you already, like, not everyone has a lot of time, not everybody has a lot of staff, but I think that this is a really helpful message and really helpful to approach that I would love to try more of and love to see it like researched through. But I think that during pregnancy, right, and in that and in the and after pregnancy, right, where you all focus, there's a lot of opportunity for supportive people to learn and get information from you about things that they could watch out for. And also, there's a lot of opportunity where maybe that person who's the other caregiver maybe just needs to talk or ask some questions or, whatever. So this sort of gives both, if it's both parents or both caregivers, or if it's that situation where it's someone else's, where it's somebody's mom, it really, you can create some opportunity by, like, hey, I'm gonna talk with this patient, and you're gonna go over here, and we're gonna, we have some information we share with every new parent, and maybe this is an opportunity to use some, like, Hear Her Now campaign materials that, like, if somebody has headaches, some routine screening. Hey, how are you doing? Some opportunity to kind of get that other person out of the room or starting a visit that way, instead of saying, hey, now I need time alone with my patient. It's always okay to say, hey, I need time alone with my patient, but sometimes that makes that person that's being asked to leave resistant or think that you're being, like, accusatory. And that's not the case, but some people interpret it that way and really dig in. And also, if that has happened and if person is abusive, that survivor knows this is not the time to necessarily convey that. So just trying to find some excuses to check in with that other person, give them information that may be helpful to them and to your patient, sometimes would be a helpful thing. Normalize those private conversations, right? Hey, we do this separation, or we do whatever. This is just part of our routine care. I know that there are some of you who say, like, hey, we just have the birthing parent come back first with that kiddo. We'll call you in a minute. That's great. And being able to say, this is this is just how we do things here, right? And we want to frame any kind of screening, or if someone's being told, like, that they can't be in the room, that frame of, we do this because we need to provide or get information. It's not about removing someone. So I'm just curious, how does this feel? Like, is this something people do? Anybody who's like, absolutely not, like, this is our idea this is my idea in terms of what I hear, what I see, what I think sometimes could feel helpful. But how does any thoughts on this frame? And again, please understand, I'm not saying you have to, like, change everything about what you're doing, but I think sometimes we can maybe think a little differently about it. Yeah, I think, so someone's saying we do this sometimes when someone has a concern. For example, if a patient needs a urine test, meet them in the hallway, the logistics of space. Yeah. And I think the idea of doing that thing, like, in the hallway, right? Like, kind of getting someone out of the room is such a great idea. I think if you can figure out some strategies to like, and I'm sure that this already happens, like even before you have that concern, right? Trying to do some things that feel universal. It's just food for thought. If anybody tries this, I know we've had some small birthing hospitals in Pennsylvania that have done this within like labor and delivery. If anybody tries it, let me know. See how I'd love to learn more about how possible this is. And you also make it information that would be helpful from that significant other. I'm seeing another place to do it. Things with is MA's medical assistants. Yeah, thanks. Do the wait after taking the patient across the clinic, asking a partner to take baby for weight and giving birthing parent a moment to relax, maybe a few minutes to check in. I love that idea. I'm gonna steal it and put it in these slides. So normalizing feels like a good approach because it's what we do with other things like universal screening for mood disorders. Yeah. And I think the sense of like everybody needs to talk about this feels really cool. I have a workflow at the beginning of pregnancy, which often involves separating the patient for an ultrasound, but it doesn't work well in the postpartum period. Yeah. And I think if there are things that can, that's a great opportunity. I love that, Mario, um that sort of separation for an ultrasound. That's a great solution that I'm stealing to take into other spaces. Right. Any other thoughts? If needed, you can always request a urine sample and have them walk away for that. Yeah. Yeah, I think remembering patient may have trauma from medical system or birth and not want to be separated from the partner. And I think that anytime you're meeting that resistance, don't force it, right? But at least try it. And I think we'll talk about that a little bit later, but whenever you are in that situation where someone's saying, I don't want my partner to leave me, it's always helpful to have something kind of in your back pocket, and I'm sure you do, maybe a couple down the road to be able to say, hey, I noticed ... Maybe it's part of a follow-up phone call or something like that, just to check in and say, how's that going? Do you have any supports that you might need? Because I think that sometimes people are told that they can't. I don't ask anyone to step out. I ask the partner if they want to be included and then walk the patient to the US room, the ultrasound room to set up before bringing the partner. I think that is great. Yeah, and these are things that you have to kind of like, this is what's hard about domestic violence and getting privacy is you have to look at your space, what your role is. And I think that like anybody can have these conversations, right? It may not look like formal screening. Keep coming them and keep putting things in the chat. This is a fantastic conversation. So I want to think about interventions, right? So do you have the privacy? You know how to screen, right? We've talked about that a lot, but then the moment of like, oh man, like this thing's happening, right? And often you may not get the answer from screening, right? You get the answer from paying attention, from having these conversations, from talking to somebody while you're walking with them to ultrasound. So these are some strategies around interventions. And we'll take a deep dive into them, but I just want to get us cooking around what we're thinking. So first thing, validating that survivor's experience, assessing immediate need, providing tailored responses, navigating documentation and confidentiality. This is really tricky with survivors because it's not just about the domestic violence, implementing in-office support when possible, and following up. So I'm just curious. I want to know from you all, which of these things feels like the thing that you're like, I'm really good at this. So hold on, let me start this poll. You should be able to see of those interventions, what feels really good. Oh, I see so many surveys. So far, I know it's not coming up on the screen. I'm seeing that people feel really comfortable assessing immediate safety needs. All right, take like one more second. All right, so I think the big winner was assessing immediate safety needs. And does that feel thumbs up, hearts? Does that sort of feel like where everybody's at? Like that feels like it's urgent, you know, you've been given probably the most skills around that. Bear with me. Poll everywhere does not like it when we switch back and forth. Okay, so in terms of we're gonna meet Jasmine, and we're gonna be thinking about as we work through the interventions. You're gonna revisit Jasmine, and I'm hoping that you all are gonna talk to potentially each other. I don't know. Uh, we may be able to do breakout rooms and teams. I don't know if we can. Great. If not, we're gonna talk about it together. But as we're working through our interventions, we are going to keep Jasmine in the back of our head. Jasmine's a 27-year-old new mom. She comes in for a postpartum checkup with her newborn and her husband, Marcus. During the visit, Marcus is attentive but answers a lot of questions for Jasmine. When the nurse asks to weigh Jasmine privately, Marcus hesitates, but he steps out. And in a brief private moment, Jasmine hesitates and quietly says, "Hey, things have been really hard at home." So just everybody have Jasmine in their head? All right, so validating that survivor's experience. This is very simple, but also I think I know. So for me, I can say when I first started working with survivors, I wanted to quickly get to the assessment portion, right? What do you need? How can I help? That this was something, even as an advocate who had the appropriate training to be working with survivors, this was a step that I often missed because my brain was like, I have to do something about this, right? And I was missing out on being able to just say like one or two sentences about like, hey, I'm sorry that this is happening for you. And I encourage you to like find the right language. And even if it's not necessarily something like for example, like with Jasmine, right? When Jasmine's saying things have been really tough at home, that's a great opportunity to say, hey, thank you for sharing that with me. I would love to to talk with you about what's happening. I know a lot of my patients experience things that are kind of tough at home. Can you tell me a little bit more? I'm here to help. You don't have to wait for the full disclosure before you start that process of validating that experience. And that's really in that trust building space. And again, I know this is one of those things you're like, well, of course, May, I'm going to validate that experience, right? But our brains are like, oh, I got to fix it. I have to start this process, right? I have to start gathering information and like learning, but just being able to like, hey, say it out loud. Do any of you all have, and if you wanted to share and drop it in the chat, anything that you say that sort of validates those like those experiences? And I see while you're thinking about what validating statements do you use, I see that Mario has a question. Do you know of any workflows that screen partners present for use of harming behaviors in relationship, turning their presence from an impediment to an opportunity? Can you say, I think I don't, but can you say more, Mario, like about like what do you mean sort of like with both people present to like talk through what's like almost like a relationship screen? I just want to make sure I know what you're asking before I make an assumption.
Yeah, I'll come off mute. We provide cards, for instance, for IPV screening in our practice, and ask, for people whether they experience any of those things and would like to discuss them with a provider, or if they've used them in a relationship, and would like to discuss that with a provider. But I'm just thinking, what if, like that was the norm at a prenatal visit when you're there with a partner, that somebody asks you if you're using harming behaviors in that relationship or any of your relationships, and that if they would like to, be connected to resources that can help them change how they approach their intimate partners. And I mean, I imagine in that moment, maybe people don't answer truthfully, but it does sort of say that this is something that we think is important, and there's resources that are not just the justice system to address violence in relationships.
I do not know of anyone that formally, you are the people who I know they're doing, like having those cards, but I think that's a fantastic idea. And I think that if we give those to everybody, and I love that question, are you experiencing or using these behaviors? I think that is spot on. I think that would be fantastic. I think it should be in every workflow, because I think that sometimes, right, like, again, we don't talk about domestic violence in terms of like gender, or in terms of like, oh, the person who is that like every person is going to be abusive, or those types of things. And we know that sometimes birthing folks may be the person who is using the violence, right? And their significant others experiencing the violence. So I think I would love to talk more if that's something that we could help with. So thanks. I'm going to keep us moving. So that validation, right? What are those things? Assessing immediate needs. You're already like, this is our space. So I'm going to go through these fast, right? Are there any medical concerns that are coming up for folks? Is going home safe? Don't assume that it's not. Don't force people to not, because most people are going to say like, yeah, going home is safe. Very few people are going to be able to maybe talk about what's happening and have the interest or the capacity to not go home right away. If someone says, yeah, going home is safe, you still can plan for safety with them, but we don't want to assume that just because someone is saying that they've experienced something, right? Like what Jasmine's experiencing. Jasmine may feel really safe at home still, right? But she needs some supports in order to plan for some safety and navigate potentially. And then just generally like, hey, what can we do to help you today? Sometimes survivors may have a need that they didn't know that they could ask for, or they maybe weren't thinking about it. And so things like, for example, a lot like, do they have a car seat, right? Do they have food? Do they have those things? What's coming up for you today that we might be able to help with? And there's different ways that you can approach that, right? But just getting to that. But you guys already have, this is your area of expertise. On your polls, you were like, yeah, we know how to do this. Providing really tailored resources. And this is where I think I love what you all talk about in terms of like the community-based resources and how are we going to connect with people. I think that is incredibly important. I think it's also important that they're trustworthy, right? So having the opportunity, hey, do you have a list? Who do you refer to? Because I think it's very simple to think like, oh, we're only going to refer to the local domestic violence program, right? And that's great. I think that's always important. That should always be step one when someone is experiencing violence. I also think you shouldn't necessarily call them the local domestic violence program, right? Because some people are like, oh, like maybe Jasmine is not feeling like this is domestic violence, right? Maybe Jasmine is feeling like, hey, I need a little bit of help in my relationship, but she may be really floored if you're like, we need to call I'm going to tell you about the domestic violence program. So being able to say, it was already on your screen. So Lutheran Settlement House, being able to say, hey, there are people who work at Lutheran Settlement House who work with folks in your situation all of the time. They're not going to tell you what to do. They're going to listen. They can provide some support. Would it be okay for us to help you connect with them? Because again, words matter. People get really scared because, to Mario's point, many survivors often think that your response is going to involve the criminal justice system and CYS. And that is not always, there is very narrow opportunities where that's going to need to be the case, and far more opportunities where that connection to say, these folks can't tell you what to do, can't tell you what to say. And it's super helpful if you have an idea of what happens when you call them. You don't have to know everything, but just being able to say, hey, this is how we get in touch with them during the day. We just want to make sure that you know what they do. Maybe you just help them, like, dial the hotline, tell the person on the other end, hey, this is Dr. So-and-so from this place. I'm here with somebody that I wanted to introduce you to. They can hand that phone over, right? Take 5 minutes, let them get introduced, because the minute that they start to talk, that person on the other end would be able to say, hey, I hear you have a lot going on. How can we help you? How can we connect? Also, I don't know how possible this is in every state, even in Pennsylvania, because I know it's always shifting. But sometimes the tailored resources are also things that you can do. Again, people who use violence, especially around that perinatal time frame, often restrict access to things. So sometimes being able to offer something that's telehealth, a virtual visit, some of those things, especially for survivors, can be really helpful as an option. If possible, so implementing in-office support, I realize y'all are structured very differently across the board, but if possible, things that can happen sort of in office in terms of intervention is creating a system for sort of flagging patients who may need additional follow-up in a way that doesn't compromise their safety. So the example I used when we were in person and we were in the West, the example I would tell people is, remember when we had paper and like folders and stuff, right? They would say, hey, can you grab a purple folder for me? And people who would hear it, right, could then be like, oh, this is going on for this person. Let's figure out how to do this. Is there a code word that you could put in the chart that you wouldn't know, right? And nothing like weird, not like the llama sleeps at midnight, but something that would help people who see that patient the next time, a cue that doesn't seem obvious, wouldn't strike anybody who is reading the chart as odd, but that there may need to be a little bit of follow-up here around intimate partner violence. Establishing partnerships with on-site advocates or local programs for immediate support. Many of our local programs respond in person, many do not, but at the very least, being able to figure out under what circumstances could someone come here, or who's here that has the time to maybe sit with somebody for 15 minutes to make that connection. And then, of course, always talking and making sure that staff are trained to be trauma informed and survivor centered, because you may have the very best approach. Your intervention may be spot on, but if someone has an experience where maybe they're walking in the next time and or walking out, and the person who gives them their appointment card says, well, you know what you should do? You should just leave. Oh boy, right? That lack of a trauma-informed response can make somebody not want to necessarily come back. So just making sure everybody has that general knowledge is super helpful. All right, this is my soapbox. You ready? In terms of interventions, it's really dangerous to record what the intervention is in the health record. And I know that you all have to record so much in that record. So I want to just put this out there as food for thought. I'm not going to have a guaranteed answer, but in terms of thinking about interventions, we have to think about this as the reality. My chart and patient portal access really are things that people who are abusive can use to get a lot of information about a survivor. And it includes things that I know that for a long time people were always like, yeah, like I mark it private if I talk about domestic violence, or you can't see the results of the IPV screen, and that's great. But there's lots of other pieces of things, especially around social drivers of health, that may be something that a person who's abusive could use against a survivor. If a survivor's saying, I don't have enough food, and that's visible, because that person who's abusive has access to their health record because they can do the two-factor authentication, that's something that can come up and be used as a threat in family court, in custody, just as a thing to hold over a survivor's head. So if possible, checking in before documenting any of those things, really helpful, really trauma informed, and really key to being able to provide an appropriate intervention. We always encourage like general language, like discuss social support needs instead of partner is controlling access to transportation. That partner may see that, and it can really become something that increases danger and also decreases that patient's access to you in the future. And again, to the very best of possibility, ensuring that pediatric records don't include details that could be used against a survivor. Go ahead. Is it Hannah?
Yes, hi. I'm an OBGYN, and I was just wondering, if you have a state that has mandatory reporting requirements regarding certain things, kind of how do you handle that without, of course you can report without putting something in the chart, but you probably need some sort of documentation that you've done that. Do you have any strategies that you advise for kind of how to handle that?
Yeah, so in terms of thinking about I guess my question is, what are you reporting? Are you in a state where it's required to report child abuse, or are you in a state where you have to report that there is domestic violence, or is it both?
I guess this touches on a little bit of a different idea for me. If not necessarily in this patient population, but for instance, like elder abuse and stuff like that. I've had to report that in the past, and we do have a requirement for reporting. And so I was just kind of wondering, I didn't ever think that I should have maybe not documented in their chart that, I had to report this, but now thinking back on it, I hope I didn't cause any harm. So do you mind providing a little bit of information?
Thank you for the context. I think if it's possible to make that a private note, just so it's not visible. So I think obviously like you want to protect yourself, right? If your policy is, reported, if it's possible to make it private. I also think that it's a good conversation to have with your health network to say what's the language that's required, because often the report, like at least here in Pennsylvania, the report that you would make would already have that info in it, so that that's the appropriate record of your due diligence here. And I think making it private, making sure everybody kind of knows to do it. And also what could it be called in the chart, even if it's being made private, right? So made appropriate referral to county resources, or, however you would call it. That's a really good question. Any other questions? Thank you. All right. So, and then following up, I know not everybody is necessarily, you all are not always charged with doing the exact follow-up, but being able to talk about that as a possibility. Hey, I'd love to see you in a couple of weeks. And this is also really helpful if they have, it's really hard for survivors if they have a kind of a partner who's controlling, to say, yeah, the doctor wants to see me in a couple of weeks, but I don't know why, right? But if you say, hey, we always want to see you whenever we hear this, we want to see you 3 or 4 weeks after. We want to do, we want to test for you and just check in with you, see how you're doing, whatever it is, so that survivor can say, oh yeah, I'm going to go back in 4 weeks. And that you or your staff are going to have to maybe add some of those resources in. Always encouraging ongoing conversations about safety and well-being, checking in and finding out who are the other staff who may be able to offer sort of additional supports, who would also be helpful to maybe know and talk about that this is occurring. And developing a referral and follow-up protocol for patients who don't disclose, but people with whom you have some concerns. We can't always say exactly what this would look like, but just being able, again, to sort of understand that there's a lot of times when you may want to intervene, but you don't really have anything to intervene on, but you're feeling it. And so just kind of being able to think through, how can I not lose track of this? Who else could help me in this space? and sort of tapping them in. And as a sideline in terms of following up, if you are ever like, I don't know what follow-up looks like, or I don't know what resource to offer this person, you can always hop on a call with a domestic violence hotline, whether it's the national hotline, your local hotline, and say, hey, I have like 2 minutes. Can you give me a couple of ideas based on this situation? Those are completely confidential calls. You don't have to tell the patient's name. You don't have to say your name. You don't have to say anything. But those can be opportunities to just sort of say, like, I don't really know what to do. Or if you are sitting and you're feeling like, I'm worried about this person and I don't know what to do, you can always call and have a completely confidential conversation. You may not get a fix, but at least we want to make sure that that is not something that you are carrying with you every single day. All right, so we're going to practice some interventions with Jasmine. All right, here's Jasmine. Remember, she's 27. Things have been really hard at home. And you do all that great stuff, right? And Jasmine finally says Marcus controls their finances. He limits her access to money and transportation. He's taken her phone on a couple of occasions, making it hard to be in touch with her family. He's also going to insist on being present for all of her appointments and making it really hard to ask for help or explore resources on her own. Got it? We know Jasmine, right? Have any of you ever worked with anybody like Jasmine? Yeah. Okay. So here are the questions. And I don't know, are breakout rooms possible, or is that a no? And it is fine if we want to talk through it just as one big group.
I would say breakout rooms are possible. Just time check. We have 19 minutes left. So up to you.
I don't have a whole lot left. So can people go chat for 10 minutes? Because I only have like one more slide, I think. So, and we already covered it.
So I will open breakout rooms and you should be, it should just pop up and you should be randomly assigned.
So just sort of talk about what are those strategies that you would use with Jasmine, and also just generally, what's coming up for you all? What questions do you have? What do you need to know moving forward, not just with Jasmine, but as this conversation goes on?
it looks like I have yours. I have this Sarah, their last name, 511@yahoo.com.
Yep.
Okay, perfect. All right. Yeah, and I can call you back too with the prices. And then I think that's all we need from you for now.
Okay, great. Thanks so much. I really appreciate it.
You're welcome. Have a great day.
You too. Bye-bye.
Do you feel like you're ready to have people come back?
I'm sorry, I had it muted because of that person. What I missed what you said. Who was talking about something on Yahoo. So I missed what you said. I'm sorry.
No worries. Do you feel like you're ready to have people
Yeah.
come back?
Yeah, that would be
Let
great.
me try to do this. This is practice for our breakout sessions later.
I'm always worried about breakouts in teams. Like I'm always like, oh, so thank you for doing it. I really appreciate it. I love it when people come back from a breakout room because we sometimes get to see people's faces for like 2 seconds longer. So it's very exciting. Really quickly, is anybody willing to just sort of share anything that came up in your breakout room that you want to elevate or ask?
I think the biggest thing that came up in our breakout room was this idea of charting. You know, if we didn't chart it, it didn't happen, and also for follow up with another provider, knowing what has been done and how to do that in a way that's safe for the patient, recognizing the access as well as protects the provider and allows for appropriate continuity.
Thank you. I think that is that is sort of the new frontier of this work, right? Because I feel like there's a lot of having sort of patients and other people have access to their charts, I get is great, right? Like that's amazing, but also has kind of opened the door for some of this stuff, and there hasn't been much conversation. So if anybody wants to start a conversation about it or keep a conversation about it going, and wants the domestic violence angle on it, please tap me in. That's my whole job. Anything else coming up?
You just want to say, I think this is all people from one breakout room, and the other people from the other breakout room haven't left their breakout room yet.
Good stuff might be happening. Or it's teams being like, you're staying here. Anything else in this breakout room that kind of came up? And I really appreciate the there's no good answer, right, around charting, right? Everything that you're bringing up is really important. And so is the terror that survivors that even if you all do it, right, it sort of has to be this, like, how do we normalize this, this sort of concern and accurately be able to do what medical records are intended to do, which is to inform you all.
We were also stating that most of us are in academic centers with residents where we have integrated behavioral health, which really actually takes some of the burden off of us. And we have them there to kind of like bounce off, or even sometimes to separate people, which makes it probably a lot easier than people who are not in a setting like ours.
Mm-hmm. Yeah, I like that. And I think sometimes just being able to pilot and try some different things, because I always think like if you can sort of make it universally safe for everybody, it'll work for people who are survivors and also people who aren't, and you'll get all that great extra info that may be helpful. All right, while we wait for the rest of the other breakout room to make their way back, hopefully we didn't lose people. If they did, that's on me, and I'm sorry. What?
It looks like everybody is here.
Okay, cool. Any other thoughts from breakout rooms that you wanted to put in this space? One more thought. I share this with everybody because I think this is tangible, and this is one of those things that people, I think we always think about, like intervention and disclosure, but for a lot of folks, they may not want to disclose, or it may not be safe, or it's not happening for them, but it's happening for someone that they care about. For me, I always talk about having a piece of paper that everybody gets, or something on the portal that's visible to everyone, that has 4 resources on. Who's your local substance use provider? Who's your local community mental health provider? Who's your rape crisis center? And who's your domestic violence program, wherever you are. And having those 4 buddies, or whoever else you want, if every single patient walked out and every single significant other walked out with plain language information about them, it may reduce the concern that like people aren't getting those resources. So putting things in plain language, making sure that everybody gets the information about those available resources, prepared in collaboration with the folks who work for those resources, help to ensure that if you're working with someone and you're concerned that sharing information with them might be dangerous, this is a strategy to make sure every single person is getting that consistent information across the board. What we are trying to move away from as a movement is just trying to like slide someone a hotline card, right? Because even though that's really important, sometimes it can be dangerous, and it also means that it's disclosure reliant, and we want to kind of craft environments that don't rely on disclosure. I'm going to stop sharing. I'm going to put my info in the chat. I'm excited that I get to be with you all today and hear more about what you're doing. So I will be here. But does anybody have any questions, any concerns, stuff that's, yeah, I love that. That's a great place in the bathroom to have them. It is sometimes the only place where there is privacy for folks. Any other questions, thoughts, worries? What else would be helpful? I'm just curious to have information about or on. All right. Well, I'm going to turn it back over. Thank you all for what you all do. Please know this is, I'm not just here because I'm like, oh, I like to talk about this. Very, very genuinely the intersection of pregnancy and domestic violence and healthcare is where I spend my time. So I want to know what makes the most sense for you all now, today, in the future. If I can help you in any way, please just tap me in. And again, thank you all for letting me be here today and the great stuff that you're all doing. I'm so excited.
Awesome. Thank you very much, May. Very much appreciate the presentation. And I think this is a great example of network collaboration and trying to build some partnerships. So I appreciate you coming back and chatting with us some more and looking forward to working with you more in the future. All right. I am going to, Shay, are you good with me sharing the slides?
Yes, please, and advancing them if you could.
Awesome. I will do that. Let me pull these back up. All right, I'll let you introduce yourself real quick and then I'll pull up the video since that's next.
Good morning, everybody. My name is Shayanga Beecher. I also go by Shay. I'm a pediatric nurse practitioner by training. I am also the medical director for our mobile clinic at Hennepin Healthcare, and I'm going to present a little bit about sort of this unique space in which we've been delivering care through the our team with IMPLICIT, especially as we launched. We were initially a pediatric mobile clinic, and we launched a postpartum pilot program last year, and I wanted to share some of our story with you today. If you can go to the next slide, and then instead of sort of boring you with the details about our program, I just wanted to share a video that we put together that highlights both the pediatric side and postpartum side of our work. The Hennepin Healthcare Mobile Health Program is a way that we as a health system meet
best and worst dinner foods for your gut.
Sweet, but
deliver care.
We're looking at risk families and communities that are not accessing the system.
We want our patients to be seen. We want our patients to do regular routine checkups. That's important.
Stand by, sorry. Sorry, I got a notice that we weren't seeing the video. Is that? Okay.
I think we were able to
I
see
can
it.
see it. I apologize. I got one message that someone wasn't able to see it.
I wasn't either. I could hear it though.
Can you see the screen, the YouTube screen now?
I only see AF.
Can you see it now? Cindy and Amy, can you see it? Okay. Cindy, can you see it?
I can't, but I don't know if it's something with how I'm on Teams, but yeah,
I'll make
I
sure to
tried-
drop the
I tried
link
to-
in the chat.
Great, thanks. And I
Someone
can
suggested
hear it, so-
minimizing and then maximizing, and that worked to make it pop up.
Okay. But if you move forward, and I can look at it if you share the link.
Postpartum care for mothers, environments that could be a school, a shelter, really anywhere that will have us. We also will go to patients' homes and complete these wellness visits. And we also provide postpartum care for mothers and their infants.
Care does continue after the mobile visits. We connect people with providers within the broader Hennepin Healthcare Network.
This is a really valuable resource that can fill a gap in care and help us reach more patients and make a greater difference in the community as a whole.
The families that we serve experience a lot of different barriers to care.
When people have just basic needs for housing or for food and water, health is probably the last thing on the list of priorities. We have to stand as a society and say that we care.
By providing care where they're most comfortable, they are more likely to open up as a patient and share their situation and be more comfortable during that provider visit.
It's been great to be in the community and have patients see who we are and our name and understand that Hennepin Healthcare is going outside its walls, that we are here to walk alongside them.
When they usually enter the van, their eyes light up and they go, wow, this is like a real clinic.
They also love the individualized attention and where the bulk of the time for the visit is really spent with the provider.
Really great to see people at home, offer them something that they didn't think was possible.
We don't drive, so we have to do like the medical cab. Having them come here is really easier, just coming outside, not having to fully get the kids dressed or do it. They can come out in their pajamas, like literally. This is so much better.
Most healthcare professionals get into healthcare because you want to help people. And being on the mobile unit, you really get that instant gratification of seeing how you get to help these families in the moment and make a difference.
Coming into the mobile health and being able to come out and actually like truly connect and not being enclosed in four walls is amazing. So I'm excited. I mean, like, I'm ready to go.
It's important for us in the healthcare system to slow down and remember that at the end of the day, it really is the caring relationship between a provider, the team, and a patient. And the mobile clinic is a way in which we can get back to the basics in providing care compassionately and directly with the families.
Thanks, Anna. So that's sort of a broad overview of our program. Some brief backstory. It's only it's a relatively new program. We started it in right early pandemic. And it was in the sort of janky white van because that's all we could get at that time. It was a retired vehicle from our EMS department. We stuck a stretcher in that back white van, and there was no lighting, and we had to keep the door open. We started out by giving immunizations to kids because, at least locally, we knew that the rates were dropping quite significantly. And then from there, we broadened it to include pediatric primary care. If you could go to the next slide. We received through one of our funders this small mobile clinic. It's about the size of a Metro Mobility bus, and we appreciate that because some of our inner city neighborhoods are really hard to navigate, let alone park. And we moved to this van in 2021, in addition to providing care within the mobile unit, and that's key because that's what our accreditation's only related to. We can't go into the patient homes or cross the thresholds. We also started providing care at community-based sites. So some of our biggest partners in this space are Head Start centers, where we'll see children 0 to 6 and their families, and they are below the a minimum income requirement, as well as public schools. So Minneapolis public schools and other metro area public schools. We've recently had a new immigrant surge that's now since stopped, but in 2022, 23, we saw a lot of patients from Central and South America, and there was an overflow of our shelters for unhoused populations. And so a lot of families were in hotels or emergency shelters, and we provided care at those sites as well. Next slide. A lot of our program has expanded to sort of meet patient and community need. We moved from just vaccines to well child checks based on patient need. We moved from care within the mobile clinic to community sites based on community need. And then over the course of the last, let's say 2023, 2024, we were really hearing from our partners in the public health space, as well as in the emergency shelters, like, you're already here for the child, can there somehow be involved with care for the mother? And at the same time, we were hearing, the stats come in about maternal mortality rates, in particular, the US having the highest maternal death rate. And then there was really strong racial disparities as well. Next slide. Along these same stats, we were learning that much of the pregnancy-related deaths were occurring during the postpartum period. Next slide. And then the Minnesota Department of Health put together its first maternal mortality brief in 2022, reviewing the rates from 2017 to 2019. Minnesota, if anyone's familiar with it, has long been a place in which we receive refugee populations, and there's diverse populations even within Minneapolis. The challenge, however, is that when you start to break down health outcomes by race or ethnicity, there's significant racial disparity. So in this particular graph, we know that there are small populations of those identify themselves as Black, American, and Indian. However, they contribute for the largest piece of the pie when it relates to pregnancy-associated deaths. Next slide. And we found the same sort of similarities and when these deaths are occurring as in Minnesota as they were on the national scale. Most of them occurring during the postpartum period. Next slide. So based on the feedback that we're getting from our public health colleagues, emergency shelters, and families ourselves, we decided to pilot a program 6 months from July of last year to January of this year to see if we could expand our scope to care for both the mom and the baby together. I have a plus sign here in January because we found it to be quite successful, and we're actually extending the program and looking for funding to support this going forward. The components of the pilot program is that we would, first and foremost, increase access, meaning that we would work with families that would be seen in the mobile medical unit and provide care to both the mom and the baby together. The second piece was to care coordinate or provide this sort of bubble around the dyad to help both the mom and the baby seek follow-up care or make sure that they were connecting appropriately for a period of time. And then the last piece was to provide culturally congruent postpartum doula care. We found that to be important because short of us hiring Black and Brown clinical staff to represent the patient population, we wanted to at least assign a culturally congruent doula for the family that could do home visits, attend appointments, advocate on their behalf. Next slide. This is where we decided, like, how do we define our eligible patients? And because it was a pilot program, we really decided that there's a person of color that wants this appointment or this support, we're going to offer it to them. And that seems like everybody would jump up to that. However, it's sort of a weird concept to think, one, we're going to come to you. Two, you have to step into this vehicle to get care. And three, we can provide care to mom and baby together. I think traditionally we're so used to expecting mothers to go to their own appointments while managing care for their children. And for some of our patients, that includes transportation and lugging things around. In addition to if they want the appointment, we wanted to make sure that their care could be managed in the mobile unit. So relatively low acuity, and that may not, so for example, you can have blood pressure, you can have diabetes, you can be working through substance use, but the medical acuity in terms of interventions had to be relatively low acuity for it to be in the mobile unit. The biggest challenge for us was that we could not administer IUDs in the unit, and that had to do with joint accreditation. We do administer Depo and Nexplanon, however. Common barriers that we were seeing with our patients was that there were moms with multiple children, anywhere from 2 kids to 6 kids, and managing all of the child care or the child appointments became a challenge for moms to seek care for themselves. And then, of course, transportation challenges, whether it's public transportations or medical taxi cabs. We worked specifically to look at no-show lists, meaning for patients that had been scheduled a postpartum appointment and then failed their first, second, or third appointment. That was a great chance for us to re-engage with them and ask if we could come out to them. We had to make sure that the infant was at least 6 weeks old so that they could get their 2-month vaccines, and that would enable us to provide the full well child check for the baby while also care for the mom. And typically we serve patients that were either new immigrants, whether undocumented refugee asylum seekers. We often worked with families that were unhoused, meaning that they were either in a shelter or they were at a friend's house or a cousin's house or couch surfing, and teen moms. Next slide. This was a great opportunity for us to be involved with the IMPLICIT model. First, the Hennepin Healthcare, for those who aren't familiar, is Minnesota's largest safety net hospital. That means traditionally we already serve low-income patients, those that are uninsured or vulnerable populations. And we found that the mobile clinic was sort of the safety net of the safety net. So we were finding and working with families that had further fallen through the cracks. Like I said, we were able to see the baby and the mother together. And when we created this program, the goals of the program already aligned with some of the metrics of the IMPLICIT model. So we were screening for factors that we knew contributed to the maternal morbidity and mortality through our MDH reports, through our health system, and we knew that were sort of red flags. So screening for safety in the home, intimate partner violence, which our previous speaker discussed well about, mental health, anxiety, depression, substance use disorders, and what we call now social drivers of health. Are they food insecure? Is their housing stable? Are there financial strains, transportation challenges, and then also reproductive health? Is there appropriate spacing between one pregnancy and the next? So this is goes into like who our patients are. If you recall, I was talking about Minnesota experienced a newcomer surge or a new immigrant surge between 2023, 2024. Primary or most of those patients were families from Ecuador, and they were either families with young children or families with pregnant mothers. And so the bulk of our patients for this time period were families that were identifying as Latino from Ecuador, followed by those that identify as Black. We had a few patients identified as American Indian. The majority of our patients were Spanish speaking. We did have a Spanish speaking nurse midwife, which was really helpful. We also have a Spanish speaking community health worker. The range of ages one more thing about the languages. For languages such as Somali and Amharic for East African families, we didn't have in-person interpreters on the unit, but we did have access to telephone interpreters that are a part of our health system. The birthing parent age really varied. Like I mentioned, we did have several high-risk teen pregnancies, but anywhere from their typical reproductive age to older as well. This is a snapshot of our ICC screening summary, at least for 2024. Again, we did not initiate the screening questionnaires until July. That gave us a really good opportunity to sort of prep in terms of how is this going to look like for the workflow between our physical staff on the mobile unit? How is this going to look in Epic? if anyone can relate, Epic was our biggest barrier in trying to making sure that we had the capacity to document and upload into Epic appropriately so that we could have continuity of care from our mobile unit to other health systems to community resources, also pull the data to evaluate it later. And then, as greasy as it sounds, bill and code for it so we can make our sustainable model for the patient revenue. We screen for, like everybody does, smoking, depression, family planning, and multivitamin use or folic acid. This is for 2024, but again, we've only collected data from July to December, and then this does not include the data from this year, but that's also available and is similar to the results here. Here's the issue or the results related to tobacco use. The results of screening. Most of our patients have not engaged with tobacco use. And I want to put an asterisk on the word tobacco. And I'll get to that later because we have to consider marijuana use as well in our patient population. And then for the ones that did screen positive, it's mostly providing education, reinforcing cessation, how important that is. And then what was interesting is that although mothers or birthing parents were less likely to jump on the bandwagon and say, "Yeah, I'm going to stop smoking," they were very interested in how to minimize that risk or secondhand smoke to their infant, whether that's removing the clothes or smoking and then outside of the home as opposed to inside the home. Next slide. Mental health is a strong focus of both our inpatient labor and delivery teams as well as our mobile unit. There were families that were screened positive for the PHQ-9. As a side note, we also use the GAD to screen for anxiety as well. But this is looking at the implicit model screening. I personally think that everyone should screen positive for mental health support during the postpartum period, but this is specifically looking at that screen. And thankfully for a lot of the families that were positive, they were already under treatment and assessed either prenatally or during labor and delivery. Families were prescribed medications, and then others were referred out to other departments within our system. So we have a mental health department. We also have a program called the Red Leaf, which is family therapy. So mom and baby are taken care of, and there's outpatient programs and day clinic appointments versus day programs, and then women's health as well. For those that declined treatment, it wasn't sort of the end of our engagement. We would follow up with them in 2 to 3 weeks with our care coordination team, check in and see how they were doing. And for those that declined treatment, we would still provide them with resources to crisis mental health through the community or public health agencies in the county. These are the results of our family planning screening questionnaires. We were very lucky in that we could provide long-acting birth control on the unit. The frustrating part for us is that we couldn't do the IUD, and we're still sort of pushing or against that to see if we could change it in the future. A lot of families, or our health system does a nice job of addressing birth control at several points during the pregnancy through postpartum. So some families did have that engagement prior to the labor and delivery hospital discharge. Others, we got the long-acting birth control with us. And then for those that were interested in the IUD, we administered Depo sort of get to the point of their appointment with the IUD. And then unfortunately, anecdotally, a lot of the teen moms were hesitant or reluctant to engage with birth control during their visit. So there were a few parents that declined intervention. Next slide, please. And then folic acid supplementation. This is always a fun conversation to have with parents because I think once they have the baby, their focus goes directly to the baby and how the baby can become healthy. And everyone hears about folic acid during the pregnancy, but not necessarily as an ongoing support for the mom's health. And so we framed it under multivitamin use. The midwife was able to prescribe multivitamins. We did have GoodRx coupons or ways to help with that. The challenge was for our patients who were unauthorized. Backstory, up until January of this year, unauthorized immigrants were not eligible for health insurance. So a challenge became with pharmacies and prescription medications, and that was hard to navigate. Starting in January of this year, our state insurance plan allows everybody to be eligible or participate in health insurance, regardless of citizenship status. Another asterisk is that given the current landscape regarding immigration, families are reluctant to participate and or enroll in state healthcare insurance. So we're still not just with multivitamin prescriptions, but any prescriptions for a population who are unauthorized. It's a challenge trying to get folks to participate or pick up their scripts. Regarding the question about why I cannot provide an IUD, sorry, in the chat box, it was a regulatory issue with our accreditation and compliance team. It was considered to be too invasive of a procedure to provide in a mobile unit. However, given that it was a pilot, we were actually recommended to not do the Nexplanon and the depot. We were able to change that opinion, and so our goal is to sort of explore the IUD question a bit further, but we wanted to get the program up and running, so we were okay with not offering it right off the bat. Did I answer that question? Going on to sort of the impact of our program, I want to just highlight that we are capturing a patient population that tends to fall off the radar of our healthcare staff. About 67% of our birthing parents had previously no-showed to at least one brick and mortar appointment. The average no-show rate for our safety net hospital for postpartum is about 30%. That depends on the different patient clinics, and our postpartum no-show rate is 7.6%. We do a really good job of harassing our families and following up with them. So on the events that they don't, it's hard to get out of bed and come downstairs and go out to the mobile unit when you have significant depression or you're working through all sorts of issues. And so we try really hard to connect with our families if they no-show our appointment. The families that we lost follow-up to, unfortunately, have been the not unauthorized immigrant populations that, for whatever reason, may have actually moved locations physically within the state or even out of the state. Next slide. And then we were able to look at, is this crazy idea of coming out to you to give care to mom and baby together really crazy, or are people on board with it? And so we looked at whether they enjoy their experience and whether they would recommend it to others. Interestingly, that one patient that disagreed that they liked the experience she was actually running late for another appointment and felt that we took too long. However, you'll see that she'd still recommend it to others because she agreed on the second graph. And what's interesting when I shared this program to others is that the word of convenience comes up frequently in discussion about the benefit of this program. And from my privileged background, my convenience is that within a certain time frame, it doesn't make sense to me. But my standard of convenience is perhaps different than the standard of convenience of our patients, in which they're navigating multiple children or maybe multiple jobs or lack of transportation. So when the word convenience is used, it doesn't have the same meaning across the board or across the population. So when people say, oh, it's just a convenience factor, I quite sort of push back and say, well, what does it mean to be convenient for one of our patients? Next slide. So this, again, to reiterate, has, we have a small n, sorry, going back to the frame of the program. Because it was a pilot, we only offered it once a week, and we only offered it scheduled for families per day. And we may change that as we progress with the program to at least get 5 families, but we at least have an hour appointment time for each patient, and some of that drive time is included, but the N is small. But of the N, or the number of patients that we serve, I believe the benefits are really significant. One point in particular is that we have this early intervention timeframe, and potentially with the care coordination have the ability to sustain it over the period of the first year of the child's life. And because that we're screening for intimate partner violence, mental health, reproductive health, right at this juncture, it has benefits long term. And ultimately, we are hoping to sort of narrow the gaps in maternal mortality across the races. Next slide. Couple of things that came up as we were developing this pilot, engaging with Implicit, and then actually executing it was that we just have a diverse patient population. So while we have access to English and Spanish, it would be helpful to also have Somali translation, and we also have patients that speak Arabic, French, and Amharic. For the time being, what we did for those patients, we just asked the questions and the phone interpreter would then translate it, and we would sort of do the screening together. If you recall, we addressed the issue of tobacco cessation. It was interesting to note that since marijuana has become legalized in 2023, a lot of families may have actually been vaping or using marijuana and not tobacco. And so that was an interesting observation that we had. Our goal had been to introduce this model into the pediatric side of the mobile unit so that we could engage with families with kids 0 to 2. But the EPIC build and pediatric nurse practitioners documenting and ordering referrals in EPIC for an adult patient has become a challenge that we're still working through. And then we're really hoping to look at the evaluation sort of long-term. What's the long-term impact of screening for these factors and providing interventions? And if you can go to the next slide, we sort of pulled this to see, okay, if we connect with these high-risk families at a mobile clinic visit and provide care coordination, do the kids then follow up with well child checks? Are they still remaining in the system? And so we find that, you know, and this is again needs to be flushed out a bit, but there's a tendency for these families to get their well child checks and more importantly, stay on track to complete their child immunizations. Next slide. And then we looked at the maternal health. And again, this is sort of changing the paradigm in that once you deliver the baby, you stop worrying about yourself and focus on the baby. And so it was important for our team to make sure that moms received a primary care appointment. Some of our moms had hypertension, diabetes. Some of them wanted help with physical therapy related to birth trauma or issues related to pregnancy. And so making sure that these follow-up appointments with specialty care were not only scheduled, but then also completed. And then another thing that came up a lot was families that wanted dentistry. In Minnesota, you can get medical assistance for up to 12 months after delivering for yourself. And so trying to get all these appointments scheduled and completed in that 1 year after delivery. And then we also looked at emergency room visits to see, all right, we're familiar with the patients that don't seek brick and mortar appointments following up in the emergency room, and can we minimize that risk by offering a mobile clinic and follow-up engagement? Next slide. So our goal, our hope is actually that we're going to keep things as is for our postpartum mobile clinic with mom and baby, keep entering in the data so that we can support the implicit model. But we also want to support mobile healthcare as a mode of healthcare for more of these high-risk populations, and ultimately sort of disseminate these results so that we can continue to advocate for alternative models of healthcare for disenfranchised populations. I believe that's it. Yes. And I just put my name here in the last slide if anyone has any questions.
We have a minute or two for some questions if anyone wants to ask any right now. So one in the chat about funding sources.
Oh, right. So we do bill for insurance, and that helps to provide our funding for our billable staff. However, currently all of the non-billable staff are covered by other sources of funding. Initially, it was state and federal, and we actually are Hannah knows as we just got word that some of our state funding has been eliminated. in this last round of cuts. And so we're trying to move towards more philanthropy in the interim period, especially for postpartum. So it's a trying to maintain a diverse portfolio of funding for non-billable staff has been a challenge, especially in the current landscape, but our goal is to become sustainable with patient revenue and legislation that helps to provide some greater level of reimbursement for mobile clinics.
And Hennepin is one of, I believe, 6 or 7 Minnesota sites that participated in a Minnesota Department of Health grant opportunity that provided some funds to help start their journey with Implicit and get started. And some of those funds helped with Implicit dues and also travel to network meetings, and then as well as supporting some of the IT data costs and provider support. So I think that definitely was a great way to help get started with connecting you all with Implicit, and a great model that has been successful for implementing in Minnesota. Hannah?
Yeah, I know you talked about some of your funding sources. Do you have any ballpark estimate about the cost for getting this up and running and then its annual operating budget or operating cost?
Yeah, we're pretty skeletal in the resources that we are utilizing, and it could probably be better supported with staffing and resources, but at very minimum, I would say about 1.2 million for both programs, meaning peds and postpartum. And I would have to look at the details to figure out what is specifically peds versus postpartum.
That's annual operating or kind of the
Correct.
Startup and purchase of the bus and that kind of stuff?
Oh, that does not include the bus. The bus itself was about 200,000, I believe. It is I don't know if, do you have pictures, Anna? If you could go back to the photo of the bus. We specifically chose, like I said, a smaller unit, one that costs less, but also it's easier to navigate. We don't have a bathroom. We don't have a wheelchair lift. It's really just an exam table, which again, we can do the depot and the next one on cabinet space. And then in that corner, you can kind of see a desk where the provider can sit. And right next to that desk is additional seating. We actually made a specific we're intentional about having enough seating because we do have larger families, whether multi-generational or multiple kids.
And the 1.2 million annual operating cost is approximately, that's including your billables?
Right.
Okay.
Right.
Our team, oh, sorry. I was going to say
ahead.
our team is primarily we staff APPs or nurse practitioners, midwives, nurses, and our driver is actually an EMT that participates in the care so that we can make sure that everyone's sort of duly trained in their roles since it's a small team.
Right. Any final questions? Awesome. Thank you very much, Shay. If you could maybe put also your information in the chat. I think also if you're interested in kind of connecting with Shay, please let me know and I can help facilitate that as well. I know with some of the funding issues starting, you can't participate fully in today's meeting and have to jump on other meetings. So thank you very much for taking the time and joining us, and love to see what's happening and kind of seeing Implicit implemented in a new and novel way. So thank you. All right, so now we have reached kind of our halfway point. So we're going to be breaking until 11:30. So please try to join us back here at 11:30. Yeah, take some time, stretch, coffee, other beverages, and snacks or whatnot. Thank you. All right, we'll give everyone a couple more seconds to come back and join us. Julie, are you back?
Yes.
Awesome. Are you okay if I share the slides and just control it and you let me know when to move on?
Sounds good.
Awesome. Great. Everyone, about 20 more seconds and then we'll get started. Share my screen again. Right. So all yours, Julie.
Okay, super. So there have been some really great presentations this morning. Those are hard acts to follow. We don't have any fun videos or mobile units as part of this talk, but we do have some of those cool things at Greater Lawrence. So I'm going to be talking about postpartum depression screening reimbursement, kind of first looking from the landscape and then kind of how we did it in Massachusetts and in Lawrence. You can go to the next slide. So I should have approached this with more conversation with Anna exactly about what she wanted me to look at. But when I was looking kind of broadly, Massachusetts is one of the few that have mandates for screening for maternal mental health conditions. And there's not that many. Some have allowances. Some states have recommendations, but there are some good resources online where you can see where your state lines up in terms of a requirement, mandate, or if there's reimbursement available. You can go to the next slide. This is the kind of live tracker, which I found that was really cool in terms of looking at Medicaid policies. So a lot of billing and insurance reimbursements start with your state Medicaid, and then often there can be some legislative action, work within the state to advance it to all payers. And so there's going to be more states that require Medicaid financing than all payer financing, and this is the Medicaid chart. The green is the screening is required, the orange is it's recommended, and yellow it's allowed. I don't know, like, that seems weird that some states have a issue about like allowing the screening, but in terms of maternal depression screening. And then when you look further into this tracker, you can go state by state and it'll say if payments happens by payer. Go to the next slide. So very broadly, I feel like I'm often better at making broad legislative change in Massachusetts than fully implementing implicit at our Greater Lawrence site. So I have some strengths and some weaknesses. I have been part of the Postpartum Depression Legislative Commission since it was created in 2011. And this really started out with a perinatal state group, and I happen to be the family medicine representative to this group. And there was a group of committed individuals who put through a bill to kind of move the state forward in terms of screening and care for women in the postpartum period. And just for anyone who's looking to introduce a bill in their state, the first way to move this forward is to make it palatable to your legislators with a very low budget item. And that budget item is to create a commission. So that's like kind of like free. So you create a commission to make some recommendations, and then you can have further legislation come out of that. So the Postpartum Depression Legislative Commission has seats from the Mass Medical Society, from all of the relevant specialties. I'm the family medicine seat, there's a pediatric seat, there's an OBGYN seat, then there are psychiatry seats, and then there are other individuals who are seated with Senate or House seats appointed. So there's people involved with payers. So Mass Health has a seat at the table. There's various other insurers. There are members of the community, women who have had postpartum depression who are seated on the commission. There are doulas, there's midwifery groups. It's a really broad group of people. And we have worked together over many years to come up with additional legislation, which in 2016 led to our state Medicaid to cover screenings. And it's covered at every visit, but it is covered in the well child visit, one well child visit maternal screening from 0 to 6 months, one maternal screening, both antepartum and postpartum. And then in 2024, last year, we had legislation that went through to kind of have all insurers cover the screening, not just Medicaid. It is not enough to, make a huge change in your system, but the cost of the screening is to cover the administration of the screening. So a few minutes of someone's time, which currently is reimbursed about $9, that number is really hard to find when you look forward, but that's kind of the numbers that we're looking for. But if you have a lot of patients and if you're doing all of these screenings, it's better than $0 for sure. Go to the next slide. So this is kind of how the Mass Health reimbursement happens. 12-month period. So as a family doctor, I can bill on the mom's side when she has a visit, and I can bill on the pediatric side. This still means you have to do all of the other bajillion pediatric screeners. Those are all reimbursed separately. And then it clarifies that on one visit, you can bill for the maternal screen in the child's chart and for the additional behavioral health screens. I don't know if I have another slide, Anna. Okay. And this just kind of speaks to the evidence. I was lucky to find that someone has looked at the impact on screening and payment in Massachusetts, and it has shown that once clinics started being paid, the number of patient screening went up by 10 points. And this whole idea for, not the idea for payment, but the things that led to this happening in Massachusetts were part of small conversations. So, Mass Health doesn't have a ton of money, and I had been working with the Mass Health Medicaid medical director for a long time in this postpartum space on various commissions. And one day she's like, Julie, what do you think would happen? Like, how much do you think that would move the needle if we started paying clinicians to do this screening? And I negotiated this relationship. So I think it would help a lot because I think clinics are going to move where there's money, and it helps pay for the whole system. When there's not money, there's less priority put on a problem, even if it's only $9. With that relationship, I also was able to get her to start unbundling LARCs for birth control. That's my other personal passion. But anyway, so paying for reimbursement does help move the needle. And is there another slide?
So thank you, Julie. This slide Emily's going to go into a little bit more. This is basically taking your map and trying to break it down a little bit more for our sites, and then we'll jump into some discussion question period.
Yeah. So I just wanted to say at our sites, one of the things that has made this not get missed is we use Athena and we have encounter plans. So for every well child screening for 0 to 6 months, it automatically puts in an Edinburgh postnatal depression screen into the chart, which pops up with all of the other pediatric screeners. So this is consistently being done for our patients when the mom is present. And then we bill with a U code. You have to bill if it's, developmental screening need there was a need or there wasn't a need with the U1 and the U2 codes. The code that we use is S3005, but it can vary from state to state in terms of what is required. But I'm happy to answer any questions. I know it's kind of short.
Thank you. We'll let Emily do the slide and then we'll kind of get into the nitty gritty of discussion, hopefully.
Yeah, so basically what I've created was the National Academy for State Health Policy has a large list of all of the policy that each state has for Medicaid reimbursement for maternal depression screening. And so this is a screenshot of kind of half the table. So it is there is some even more information that I didn't include on this slide. And we'll be sending out this table. And then again, hopefully this will be something that we can put on that membership resource as part of the website as well. But this just breaks down for all of our implicit sites. So instead of having to kind of go through and find your state on that website, we'll have a resource that's created just for the sites that are part of our network. So this will have whether the states allow, recommend, or require maternal depression screening, the codes and the rates for each state, whether or not it has to be billed under the child ID or the mother ID or either, as well as the maximum allowed usage, which I just want to touch upon. So for Massachusetts and Mississippi, they reimburse for maternal depression screening up to 6 months. They're for Connecticut, Minnesota, New York, North Carolina, and Pennsylvania, they do reimburse up to 1 year. However, 3 of those states do, even though they do reimburse up to 1 year, they do recommend the first 6 months. And the 6-month screening is usually based upon that AAP recommendation. They recommend screening at the 1, 2, 4, and 6 month visits. There are a handful of states that don't have any